There was a wonderful line I remember by Arthur Clarke, which is that any sufficiently advanced technology is indistinguishable from magic. Your lab and your company has come up with a singular blood test which is able to establish the absence, the imminence, or the presence of cancer. You're using causative biomarkers, you said, which show up in blood 18 months before the cancer shows up. This is like 12 to 18 months. This is like the Minority Report of cancer. This is apprehending the perpetrator before the crime is committed. It's like a psychic test. This is gold. Please tell us more about it, and how did you chance upon this magic? What is the story of the development of this process?
You know, I've said this publicly. Many breakthroughs are made by mistake. And the reality is that we're not magicians, nor are we the smartest people in the world. But frankly, we got lucky. We were a drug company that was working on a cancer drug. And while studying the pathways, we realized the drug is acting on the small population of stem cells. So we've already got our US patent granted 4 weeks back, and we have published the science in Oxford Academy Stem Cell Journal 2 months back. For anyone that has not read it, shame on you. The breakthrough was that this particular molecule was acting on the stem cell, and we realized that there's an epigenetic change happening on the stem cell that is creating a cancer stem cell. The cancer stem cell creates a cancer cell. 1 billion cancer cells form a 1 cubic centimeter tumor. Once a tumor matures, it sheds CTCs. And when the CTCs break down, ctDNA and cell-free RNA. Every liquid biopsy company was looking at these resultant markers of the tumor, CTCs, ctDNA, cell-free RNA, which by definition come after the tumor has matured or already formed. We had just stumbled onto a causative marker. These cancer stem cells are showing up in the blood a good 12 to 18 months before the tumor even forms. But there's a very interesting fact about these stem cells. Because they are natural stem cells, right? They give a reading for non-cancer. So they give a reading for people like you and me that cancer is absent. Right? It gives an elevated reading when something is growing wrong in a primary organ that's imminent cancer, and still another reading when cancer is present. Right? Now, why is this important? When we look at a tumor-based approach, a CTC in the blood indicates cancer. Absence of CTC or absence of tumor cell indicates non-cancer. Absence of evidence is not the same as evidence of absence. We get a reading from our cells of non-cancer. And the interesting thing that we have about these specific cells is that, remember, there are multiple cancers that don't even produce CTCs, right? But these particular stem cells are naturally present in all our blood samples, right? And because we are able to enrich them from the blood, we get a reading. We always get a reading, even in non-cancer patients, right? And when it goes beyond a certain level, we know that it's indicative of cancer. Now, having said that, if you've read our report, we had actually got a very, very high sensitivity in the clinical study that was done in India. We have 2 clinical studies on right now with NHS. But having said that, we've done thousands of samples in India now. We get 93% sensitivity, but the beauty is we get 93% at stage 4, stage 3, stage 2, and stage 1, because we do not have the problem of not being able to enrich our cells, right? While with the CTC-based approach, I think NHS has gone public and said no liquid biopsy company is getting more than 20% at stage 1, more than 30% at stage 1 and stage 2, but you get 90% by stage 4. And a lot of oncologists have already written blogs, well, we don't need to detect cancer at stage 4. There are many signals. We need it at stage 1. At stage 1, you're not getting good data. The difference between our technology and them is we get sensitivity at stage 1.
You know, when you start thinking about presentation of cancer or formation of solid tumor, It starts to really, the more time you spend thinking about it, you realize that how the tumor microenvironment is such that it fosters the growth of tumor. So how does a prostate cancer actually metastasize into bone? Why that tumor the microenvironment of bone actually has a better homing for prostate cancer. So we look at these mechanisms of immune evasion and transition to so one of the family of proteins that we look at from the cancer perspective in our group is on mucin 1. So mucin family is a very, very important family of proteins. So that's what generates mucus when you have infection or something. So they are lining all the epithelial ducts, so breast duct, pancreatic duct, lumen of your lungs, esophagus, oral cavity, breast ducts, and all of them have the lining of MUC1, mucin 1. And what happens is that mucins are very important protective molecules. It's like the lubricant. So something will be trapped by the mucins. They're like a web, and they'll trap, and you spit it out, a mucus coming out. And so presence of mucins actually triggers when a cell perceives that it is under attack, the survival pathways get triggered. So what cancer cells, most of the solid tumors, so 80% of tumors, which are solid tumors, share this pathway that they start overexpressing MUC1. Okay. So they have 100-fold higher expression. And MUC1 is upstream of your biomarker for stemness, because it is the complete reprogramming of stem cells. What we have found is, so healthy epithelial cells are also expressing MUC1, but the cancer stem cells are expressing MUC1 100-fold higher. Okay. The problem happens when these cancer cells produce MUC1 in very high concentrations. The conformational state of MUC1 on cancer cells is different than the healthy cells. Okay, so that is where the physics of everything came along. So we were able to identify a conformationally sensitive antibody which would attach to the cancer cells. Okay. Another very, very fortunate thing happened, and in retrospect it makes sense. But so if suppose this is the lumen, say colon, so colon also is lined with mucins. Okay, so mucins will be on the interior of the lumen, right, where you expect the insult. You will not expect it around the colon, which is where the blood supply is, right? So in the healthy epithelial layer, all the mucins are facing towards the cavity, right? In cancer cell, so if this one cell becomes a cancerous, it expresses MUC1 everywhere, 100-fold higher. So that means if you now deliver a targeted antibody through blood, only the cancer cells have an antigen to bind to it, because the healthy cells don't even express MUC1 on the side where the blood supply is. Right? So suddenly you are able to have a therapeutic window which is 100-fold higher, because your delivery of antibody will not go to a healthy cell. And so now, it is unpublished data. Hopefully next 6 months or so, it'll be out. The therapeutics and diagnostics dovetail into each other, because on treatment monitoring, to figure out that truly that dose is therapeutically efficacious, you need precision on treatment monitoring. But I want to paraphrase your question a bit. I think the best way to accelerate discovery is to teach our kids to have patience. They need to commit now for a discovery that would be translated 20 years now at the flip of the coin. CRISPR, if it was not ready, or the work was not done by Jennifer 10, 15 years ago, it would not be ready for true prime time with less barriers. So I think there is a very fine balance between our next generation of young minds to be put into a framework of being an entrepreneur. I think this will to suffer, this will to create a new body of knowledge, commitment to creation of knowledge is extremely important. And innovation will come. Otherwise they'll all become managers of somebody else's innovation.
The more diverse your subjects of inquiry, the greater the surface area of serendipity. But I'd just like to close this by saying that, I don't think it's possible in the scientific discipline for anyone to be lone wolves. You need a kind of collision of smart people, of driven, passionate people. Translational medicine, the great success is that you build from basic sciences to applied sciences to clinical practice to public health to God knows what. But I think what we need, and perhaps a conclave such as this will bring us all together, is a logistics interface. It's like an aggregator.